here is your question. Right. If you have read and understood, kindly tell me. Considering its surgical pathology station, how would you define the pathogenesis of this patient, this condition, this patient's patho?
Yeah. Regard the case scenario, the pathogenesis of the segment carcinoma. This is a special type or diffuse type of the gastric carcinoma. The gastric cancer developed by sequence of pathological changes. The normal mucosa of the gastric lining epithelium undergo chronic gastritis due to any risk factor like Helicobacter pylori infection, chronic atrophic gastritis, and metaplasia leads to intestinal metaplasia. After that, the intestinal metaplasia undergo to change to dysplasia, and the dysplasia can be developed intramucosal carcinoma and invasive gastric carcinoma.
Okay, good. Can you please name few risk factors for gastric carcinoma?
I am not here, ma'am.
Can you please mention some risk factors, few risk factors for gastric carcinoma?
Okay. The risk factor for gastric cancer could be Helicobacter pylori infection, could be chronic atrophic gastritis, could be pernicious anemia, could be intestinal metaplasia, could be hereditary non-bulbous colorectal cancer, and could be adenomatous polyp more than 2 centimeter, and previous gastric surgery, and FAB, and could be related to the diet like nitrosamine and salt and fish food, and more common in the low socioeconomic classes.
Okay, good. Can you please tell me what is the most commonest histological type of gastric carcinoma? Commonest histological, yes.
The commonest. This is tubular adenocarcinoma, the most common histological type of gastric cancer, according to the WHO classification.
And this adenocarcinoma is what type of carcinoma? Is it diffuse?
Type of. Ma'am, I am not here, ma'am.
Why?
Hello?
Yes. I'm literally having mic in my mouth.
Okay.
Okay, can you please tell me what are the classification which is used to classify the gastric carcinoma? How can you classify the gastric carcinoma?
Classify gastric carcinoma by WHO classification into 5 main types, like tubular adenocarcinoma, papillary adenocarcinoma, mucinous adenocarcinoma, mixed carcinoma, and poorly cohesive carcinoma. And the second classification, Lorraine classification, divided into 2 types, intestinal types and diffuse types. And another classification, Borman classification, divided into intestine. Borman classification divided into fungating, ulcerative, and mixed and diffused infiltrative growth like Linitis plastica.
Good. Can you please tell me what do you understand by the term Crookenberry tumor?
Yeah, the Crookenberry. This is a tumor, metastatic ovarian tumor from the early and late gastric cancer.
Okay, can you please tell me other than adenocarcinoma, can you name few other examples which are identified of gastric carcinoma?
Yeah, tubular adenocarcinoma, papillary adenocarcinoma, mucinous adenocarcinoma, and mixed adenocarcinoma, and Borley adenocarcinoma.
Okay, and there's leiomyosarcoma as well. Okay, can you please tell me?
And leiomyosarcoma.
Yes, can you please tell me which paraneoplastic conditions are associated with gastric carcinoma? Paraneoplastic, yes.
Dermatomyositis and acanthosis nigricans.
How would you investigate that? How would you confirm the diagnosis of gastric carcinoma?
The confirmed diagnosis after history and the examination and the clinical examination and the investigation, the confirmed by upper gastroesophageoscopy and duodenoscopy. This is confirmed for diagnostic and take biopsy, and need laboratory investigation as full blood count and urea and electrolyte, and maybe need the tumor marker like CA72 plus 4.
Right. If you are looking at this image, can you please explain it to the patient's relative? How would you do it in your simple words? What are you looking at?
Okay, ma'am.
Yes.
Where is the slide?
Can you not see it?
I not see. Please share again. Yeah. This is okay, ma'am.
Can you see now? Can you see now?
Yeah, I am seeing. This is a large vacuolated cytoplasm filled with mucin. This is a signet ring cell. This is a characteristic type of the diffuse type of the gastric carcinoma according to the Lorin classification, with mucin in the central and the nucleus pushed at the periphery. This is characteristic type of the signet ring cell cancer.
Good. Which stain has been used?
Histoimmune stain.
Okay, good. Can you please tell me what is the treatment of gastric carcinoma?
Yeah, the treatment of the gastric carcinoma according to the stage and the site and the type of the tumor could be surgical treatment, and it could be palliative treatment. The surgical treatment, subtotal or total gastrectomy with lymph node clearance with plus Rowan-Y gastrojejunostomy and Rowan-Y esophagojejunostomy. And the palliative treatment as feeding jejunostomy, palliative of ascites by repeating tapping, pain relief, palliative chemotherapy, treated dehydration, treated anemia, and that
Okay. Can you please tell me what are the complications of total gastrectomy? Both early and late. How would you classify it?
Early complication. Yeah, early and late. Early like anastomotic leak, bleeding, pancreatitis, cholecystitis, infection, and late complication like vitamin B12 deficiency, metabolic bone disease, dumping syndrome, and recurrence of malignancy and the cholestasis.
Okay, patient after following gastrectomy experiences a certain condition. How would you, or what do you think that condition would be?
What's ma'am?
Patient after gastrectomy undergoes a certain condition, and it is of two types. If you can think of and then tell me.
Yeah, this is dumping syndrome. The dumping syndrome. This is, yeah.
Yes, please.
This is due to loss of reservoir function following gastrectomy, result rapid transit of high osmotic active substance into the duodenum following males might cause dumping syndrome as early dumping and late dumping. The early dumping after 30 to 60 minutes following a male leads to rapid transit of hyperosmolar gastric content into the small bowel, leads to shift of the fluid from intravascular compartment to the gastric lumen, leads to abdominal pain, abdominal distension, diarrhea, and tachycardia and postural hypotension. And late dumping after 1 and 3 hour following meals leads to rapid transit of carbohydrate into the small bowel, result sudden absorption of glucose, and leads to hyperinsulinemia, leads to hypoglycemia, symptom and sign of hypoglycemia. The
Good.
treatment frequent meals, low carbohydrate and more fat, and can be used the electrolyte for dumping syndrome.
Good. Thank you.
Thank you, ma'am.
There is your question. Right. If you have read and understood, kindly tell me. Considering it critical care scenario, how would you manage this patient?
Okay. First, when I enter the room, I will introduce myself to the examiner,
Good.
and then I will wash my hands. And then when I'll go next to the patient, I will first ask him to say his name.
There
because that
won't be
is
any
my
patient in critical care scenario. You'll just
Okay.
introduce yourself, you wash your hands, and then you'll answer the question.
fine. Okay. So considering this is a critical care, I will follow the CCRSP protocol.
Yes.
So the first thing that I will do is assess his airway.
Yes.
This can either be done by talking. If he's responsive, it means that the airway is patent. And then I will prop him onto a 15-liter mask, a non-rebreather mask, after I fill the valve and I fill the bag before putting it onto the patient. And then secondly, I will assess his breathing.
Yes.
For assessment of breathing, I will first assess the movement of his lungs first by inspection and then by palpation. And if there's an unequal movement on any of the lungs, I will then proceed. I will ask for the examiner to ask if there's any findings.
Yes. What else would you consider when you'll be
what else?
considering once you're assessing the breathing? What else is important that you'll consider?
I'll auscultate the patient, and I will also look for any open injuries or open trauma.
Trachea location.
And and the trachea location
Yes.
as well. Yeah.
Okay,
and
because
then,
this is it's central line insertion, so it's important.
Yeah.
So according to your opinion, what type of injury or what has happened to the patient?
So this patient has had a central line insertion.
Yes.
There can be a pneumothorax, and they can be a hemothorax into the lung.
How would you classify, or what are the types of pneumothorax?
Pneumothorax can either be intention pneumothorax or a simple pneumothorax. A simple pneumothorax will not usually present with respiratory distress.
Yes.
And with a high respiratory rate. So I think this would be
what are the
intention
signs that you should look for to categorize it or to call it pneumothorax?
First, I would look for tachycardia and for hypoxia and high respiratory rate. And then in terms of when you look at his examination, if his trachea or it seems to be deviated, that is, and his mediastinum as well.
Yes.
But I would appreciate
how would you
that
assess
on a chest
the
X-ray.
mediastinum?
On a chest X-ray.
What about an inspection? If there is ipsilateral reduction of chest wall movements and breath sounds.
And breath sounds as well.
Okay, right.
Yeah.
Then can you name few differences between simple pneumothorax and tension pneumothorax? How would you differentiate between the two?
In intention pneumothorax, the trachea will be deviated towards the opposite side, as will the mediastinum. And they will the lung will be collapsed on that side.
Yes.
On the ipsilateral side.
Yes.
And
there'll be tachycardia, hypoxia,
there'll be an increased respiratory rate.
Yes.
Sorry, I can't
And
think of
then
anything else.
patient will be craving for something.
Oxygen. They'll
Yes,
be
good.
oxygen deprived.
Compared to that, in simple pneumothorax, how would the picture be? How would the patient present?
And the patient will not be in a distress situation.
Yes.
There might be tachypnea.
Yes.
But there will be no tracheal shift, and the patient will not have a hypoxia either.
What should be the ideal management in this situation in case of pneumothorax?
The ideal management is, since he is already tachycardic and tachypneic, I will first ask for a needle thoracostomy.
Very good. How would you do that? What is according to the NICE guidelines? Yes.
Yeah, according to the new ATLS guidelines that's come out.
Yes.
I will have to insert the needle at the safe triangle.
Yes.
Where there's a lateral border of the anterior border is the lateral border of the pectoralis major.
Yes.
And the posterior border is the mid-axillary line.
Yes.
And the inferior border is the line drawn from the nipple.
According to the NICE guidelines, how should you do it? Under ultrasound guidance.
Under ultrasound guidance.
Yeah. Yes, that is more important, because if you're doing it blindly just in the safety triangle, that is no meaning. Okay. Yes.
Yeah. And then
what are the complications that you should expect while doing this procedure?
And there's a chance that there's an injury to a vessel, so then I might inquire to some bleeding. There might be injury to the lung as well whilst I'm doing this. And there's a chance that I can induce an attention pneumothorax.
Okay.
As well.
Yes. Could be even like the perforation of the right atrium leading to the cardiac tamponade, arrhythmias, etc. Okay, you have to memorize at least 3 to 4 on your fingertips. All right. Can you name few conditions when central line insertions are indicated?
So central line can be indicated in terms of monitoring of fluid balance or fluid resuscitation, for giving TPN, and then for giving potassium-rich or hypernatremic fluids, which is not available in peripheral access.
Yes.
Or if you cannot get peripheral access, or if you're giving chemotherapeutic agents, or for hemodialysis.
Okay. Can you please tell me what might be the technique that one can use once they have to remove the central line or take it off?
So when we remove the central line, the head must always be down.
Yes.
To prevent any air embolism.
Very good.
And then we should always use a 5 maximal sterile barrier precautions to prevent any induction of infections.
Very good. Okay, can you please tell me, when it's suspicion of infection, what are the organisms that most commonly you can expect?
So most common organisms is Staphylococcus epidermidis.
Very good.
And yeah, you can also expect Staph aureus infections.
Yes. Can you please tell me what are the measures that you can apply to prevent the central line infection?
So first of all, perform hand hygiene, perform a double wash technique with the right antiseptic, and then apply the right antiseptic to the skin. And then make sure that it's dried before you insert the central line. And when you're inserting the central line, you need a cap and a sterile glove, sterile gown, a mask, and a large sterile drape to cover the area. And once the central line is in place, whenever whoever accesses it has to use soap and water, or like an alcohol-based hand rub before touching the line to prevent any infection, and also remove the line when it's no longer indicated.
All right, good. Can you please tell me what are the places or the sites where central line can be inserted? Can you name few?
So the one that's predominantly done in the UK is the IJV under ultrasound guidance.
Yes.
They can also do a subclavian line insertion or a femoral line insertion.
Very good. Can you please tell me the anatomical landmark for IJV?
Yeah. The anatomical landmark is basically the mastoid process, the 2 heads of the sternocleidomastoid and the clavicle.
Yes.
And you also have to feel for the carotid pulse. So we have to locate the clavicle in between the 2 heads of the sternocleidomastoid. And in the center of the triangle, palpate the carotid artery and you go lateral to the carotid artery,
Very
and
good.
you insert the needle pointed towards the ipsilateral nipple in the coronal plane. You are
Yes.
directing it 30 degrees towards the ipsilateral nipple, and you keep aspirating as you advance the needle. And once you advance the needle, you use the Saldigas technique to thread the guide wire in.
Okay. Good.
And then when you're not supposed to get any ectopics on the ECG when you go in.
Once Bell has gone, the last question I'll ask you, because I'm asking you very slowly, and in the exam, what feedback I've got, that they ask you very fast, like a bullet, like one after another. They hardly give you time to think. So, okay, last question. Once you're inserting the central line and patient starts to have sudden onset of breathing, how would you confirm, or how would you investigate that? What would you do?
I think we first have to instantly. I think a chest X-ray to confirm the position of the and an
ABG.
And an ABG.
Yes, that's it. These are the two recommended mentioned here. Okay. What last question? I did say last, but then one more question came in my mind.
That's okay.
Once you are removing the central line, what might be the indications when your consultant says, or when you feel that now it's the indication, I must remove it?
Once we know that there's a focus of infection, there's any spiking temperatures, and there's a high CRP, high WBC counts, and we've done urine cultures, chest cultures, and everything is negative.
Okay.
There's a high chance that the
anything else?
Infection, and if it's no longer indicated.
Very good. When you're sending the patient home, so
when
at
you're
the time of
sending
at the time of sending patient home, or when there is infection, or when you suspect there could be infection in the central line, or when there is cessation of the cardiac support that you were giving, like, to the patient at that time, and when there is resolution of the acute problem, you don't need it anymore, so you decide. These are the 3-4. Like, for every, I would request, for every scenario, for every point. Okay, can you please? I'm sorry. We are still here. My battery has died, but okay, quickly, can you please read the X-ray? Can you please read this image?
And this X-ray belongs to. Oh, sorry.
Not even here. Yeah.
My battery's dead as well. 1 second. Ma'am, can you hear me?
Yes, I can hear you. Yes.
Yeah. This X-ray shows that there's a right-sided pneumothorax, which has caused a tracheal deviation and a mediastinal deviation towards the left side.
Yes.
It has also caused the lung fields to get shifted to the left side as well.
Yes. Left.
Yes, ma'am. It has. I mean, it's deviated to the left.
Yes. So when you're reading the X-rays, what are the things A, B, C, and D that you have to know?
Yes, ma'am.
Are there any bony abnormalities?
Sorry, ma'am, I can't hear you.
Are there any bony abnormalities? Actually, I want you to speak. I don't want to tell you the answer.
No, ma'am, that's fine. I can't make out any bony abnormalities. There's no rib fractures.
No. So that's it. One can tell. What are these arrows pointing at? Did you tell me?
Yes, ma'am. The lung that has collapsed, from the right lung that's collapsed.
Yeah, good. Okay, good. Thank you so much. So what I was saying, that whenever you are telling about any condition or any point, then just remember 3 to 4 on the fingertip. Like, if you just quickly tell 3 to 4, they'll realize that you know the question, and they'll move to the next question. So that's the way to go. Just quickly remember. Yeah. Thank you so much.